Good evening, everybody. I want to thank Dr. Jha and all my teachers in PGI for being there while I was learning the alphabets of medicine and also then nephrology. And as I learned nephrology, I found that managing a recipient with a failing kidney allograft kind of summarizes and channels all knowledge in nephrology in one way or the other, and gives an opportunity to use everything one has learned as a trainee in nephrology to give them a better quality of life. So I'll start with a real case, a patient who I am still taking care of. She's a 60-year-old lady. When she saw me about 7 years ago, she was a preemptive transplant candidate with a creatinine of 7, diabetic, hypertensive, coronary artery disease, former smoker, and a big soccer fan, and unfortunately had many antibodies against a potential donor who was a daughter. And we desensitized her successfully after waiting for a while to find a paired exchange donor, and then transplanted her successfully. Surgery went well, the creatinine was improving, and as unfortunately sometimes happens, the creatinine started rising, and by day 5 it was 9. It was more than what her creatinine was before, and she was never dialyzed before. And then we, of course, did the workup, which included a biopsy. To our unfortunate sad surprise, we found thrombotic microangiopathy and a severe form of antibody-mediated rejection. And eculizumab was still just coming out and was not available to us, so we gave her plasmapheresis and treatment for antibody-mediated rejection, and she's luckily responded after an intense course of treatment, and creatinine decreased to 2 milligram per deciliter. Not the best we want it to be, but at a point where we never had to dialyze her. And that is the biopsy, and you can see the ravaging effects of immune system here, and characteristic findings of thrombotic microangiopathy. So many questions come to our mind, when we face with one of these patients who are destined to have less than optimal longevity for the renal allograft, and a failing renal allograft in the making. So what are the identifiable causes of allograft failure? And the next question is the patient really retransplantable? Are they going to be in good enough shape for that? And is there a reason to interrupt immunosuppression for any reason, malignancy, infections, or any major side effects from it? How to modify the immunosuppression so that we can get a little more mileage from this kidney and make it last as long as we can? How to preserve remaining allograft function, so that we can extend the life of the kidney and delay the next transplant or renal replacement therapy, and managing end-stage renal disease in such a patient who has a failed renal allograft in the history, and how to prepare for retransplantation in such a case, and how to follow up these patients so that we don't make the same mistakes, or they don't have the same suboptimal outcome with the next transplant. So the major questions that comes out is the patient going to outlive the failing allograft? Can we make the kidney last as long as the patient live, or meeting the slogan "one kidney for life"? And is the patient retransplantable? And then we are in a time and society where we want to fix the blame, or want to know who are not to blame. Really, is the patient taking the medicines, or is there something that they didn't tell us beforehand? Or is it the kidney? Did we give a bad kidney to a good patient? Or was the medical team at fault by not taking judicious decisions at appropriate time to modify medications, or monitor more closely, or look at the kidney by imaging to see if there is anything anatomical that's going on that we should modify, we should address? So is it just an unfortunate, unavoidable outcome despite all the precautions and care that we take in all our patients? So looking at, we look at this patient, we talked about very carefully because of an unexpected outcome at the beginning of transplantation. So 2 years after transplant, she was admitted with fever, no cause was identified. And the team at that point decided to reduce the dose of MMF by 50%. And promptly she had a rise in creatinine. And so we biopsied her and she showed tubulitis. So this is, again, immunology showing its head at an unwanted time and place. And we pulsed her with steroids and creatinine decreased to 2.2. So, and she never needed dialysis at this time as well. So again, this was not the last time we will come across her. So we'll periodically review what's happening to her. So the immunological injuries are, the bane of all transplant, team. That is, leads to chronic rejection. Whatever name we decide to call it can, and we can retire the name, but we can't really retire the disease process. Antibody-mediated rejection is probably what happens in those patients who don't have longevity for the allograft as we expected. High immunological risk patient that we identify early on, like the patient I described to you, big HLA mismatch, suboptimal immunosuppression, suboptimal adherence to treatment, and of course a sensitized recipient who already have pre-existing antibodies, one of which the strongest reason is a prior transplant. So recipient of a suboptimally functioning kidney, can be because the organ got injured during recovery. It can happen with the, laparoscopic nephrectomy. It can happen when, a person recovers multiple organs and the kidney is not given the respect it deserves. Prolonged ischemia time when the kidneys tend to travel long distances in a large country and miss flights and so on. And loss of renal parenchyma due to, small accessory vessels. We've all seen that happen. And pre-existing diseases in the donor kidney, which sometimes is not picked up by any of the tests that we do for renal function in a potential donor. And significant donor recipient age and size mismatch. We all know that a young kidney will do well in an older recipient, whereas the reverse is not always the case from the age of the kidney as well as the immunology that is involved with an old kidney in a young donor. And mechanical and vascular and urological issues, they always are potentially avoidable, but sometimes the vascular anatomy or the blood supply of the ureter doesn't cooperate with a successful transplant. And of course, suboptimal surgical technique, though I hate to blame our surgeons since they tend to have perfected the techniques much more than the manipulations of immune system that nephrologists do. And of course, as we know more about the genetics of kidney diseases, ApoL1 and probably now shroom, all these molecules that we identify with the high risk alleles that can lead to a decreased lifespan of the allograft. Of course, recurrent urinary infections with, unavoidable vesicoureteral reflex that happens in a transplant kidney, BK virus, adenovirus, parvovirus, even CMV, recurrence of kidney disease, FSGS, IgA, lupus, thrombotic microangiopathies, oxalosis, even, the blatant well-diagnosed oxalosis is unlikely to, have a bad outcome because most people would give a liver with the kidney. But I've seen patients who have a form of oxalosis where they can treat with pyridoxine. If the patient is not very adherent with pyridoxine, then they develop renal failure with high oxalate levels. So intentional reduction of immunosuppression happens with patients who have infections or malignancies, especially major recurrent or opportunistic infections. They would warrant to save the patient, have to decrease the immunosuppression, and with the unavoidable consequence of immune system affecting the kidney as well. So what happens after an allograft failure? We do transplant to improve the lifespan of the patient and improve the quality of life of the patient. Both these goals are completely, or partially affected by a failing allograft, and leads to major causes of mortality are identified as cardiac and infectious causes. Since a good kidney function leads to improved cardiovascular health, and continuation of immunosuppression leads, and the cumulative effect of immunosuppression leads to higher rates of infections and cancers. So, what are the choices we have? Two main courses, big divisions in the future course of a patient. One is allograft nephrectomy, cessation of immunosuppression, and dialysis initiation. All things that transplant nephrologists or nephrologists who take care of transplant patients, we all like to keep kidney alive. But this may be necessary in a patient who has a primary non-function. Again, the cessation of immunosuppression is, to be decided in each case by case, but allograft nephrectomy and dialysis initiation seems imperative. Early allograft failure for any reason, vascular event, arterial or venous thrombosis, hyperacute or an early refractory acute rejection, whatever the semantics may be that the kidney didn't work, early on. Prevents, this allograft nephrectomy will prevent graft rupture and hemorrhage where the immune system really shows its ugly face. So, but it's not so clear cut, when the allograft fails more than 1 to 2 years after transplant, whatever be the cause of it. Our aim at that point, it generally is to preserve the allograft function as much as possible, continuation of immunosuppression and dialysis initiation only when it's necessary, since we know that probably the residual renal function is more important than the dialysis in improving the lifespan of such a patient. So preserving the residual allograft function may have certainly survival advantages in some models, mathematical models, and probably in real, though we don't have a lot of studies to back it up. But prevents graft intolerance syndrome and inflammation if you continue immunosuppression, whereas if you have a chronic rejection kind of situation or chronic active immune system against the allograft, that leads to a chronic inflammatory state, which is well described. And also continuation of immunosuppression is probably the only thing that can minimize allo sensitization, and preventing overt acute rejection by continuous low dose immunosuppression will reduce the need for an allograft nephrectomy and prevent an episode of acute rejection in a kidney which is not working enough to prevent dialysis. So again, some of the diseases that are pre-existent in the kidney recipient tend to have beneficial effect from the immunosuppression, such as inflammatory bowel diseases, lupus, and different forms of vasculitis. And they, if you stop the immunosuppression, they can have re-emergence and extrarenal manifestations. Of course, the price we pay for continued immunosuppression is cardiovascular risk, infectious complications and metabolic complications, and increased risk of cancers such as skin cancer, non-Hodgkin's lymphoma, and Kaposi sarcoma, and all the cancers that are associated with oncogenes and immunosuppression. So how do we preserve the allograft function? Apart from all the non-immunological factors, we also have immunology that comes to play in an allograft. So optimization of immunosuppression, what immunosuppression and at what level. Since we don't have a real test for immunosuppression, that becomes a really challenging task. Is CNI minimization helpful? We always talked about a cyclosporine clamp effect early on, decreasing the GFR like that an ACE inhibitor or ARB would do. Maybe reducing the CNI and adding a co-stimulatory blockade may be the way to go to get a little more juice from this kidney, which is failing. Again, big studies are yet to come. Managing chronic antibody-mediated rejection, of course, by giving enough immunosuppression, especially a low-dose steroid, maybe. Again, we don't know which immunosuppressive agent is going to really achieve that optimal outcome. We got to watch and manage each patient individually. Ensuring vascular adequacy. Many of these patients can have peripheral vascular disease, iliac stenosis, or renal artery stenosis. Those things need to be looked at. Managing cardiovascular and CKD risk factors, non-immunological factors, diabetes, hypertension, hyperlipidemia. Optimizing the bladder function, of course, in diabetics and people with bladder outlet obstruction from prostate will need to be addressed to help the kidney as much as we can. Nutrition, sleep, exercise, body weight, avoiding big animal proteins, getting enough sleep, exercise, and maintaining a healthy body weight. All these will go definitely a long way in definitely improving the quality of life for these patients. Avoiding nephrotoxic agents such as non-steroidals, tobacco, and of course cocaine, contrast media. So these need to be especially emphasized to patients who may be vulnerable to these. So let's talk a little bit about surgical treatments that are sometimes necessary. Allograft nephrectomy. As we talked about, early allograft loss within 6 months or even 12 months, they are twice more likely to need allograft nephrectomy unless you're continuing the same intensity of immunosuppression to prevent an acute rejection episode in such kidneys. And this is true in pediatric cases as well as adults. The early graft loss and allograft nephrectomy may decrease the panel reactive antibody after a while, even though early on it might increase slightly. Late allograft loss nephrectomy does not have that kind of an advantage in improving the allo sensitization, and in fact it may actually make such antibodies come up, because the kidney may tend to be working like a sponge in such a situation. Again, the allograft nephrectomy has to be considered for its merits as well as the risks associated with it, because there is a palpable, a measurable morbidity and mortality associated with the allograft nephrectomy, and especially in the early post-transplant period, not necessarily because of the technique or the surgery itself, but because the recipient is recently had a transplant on intense immunosuppression, and you're doing a major surgery in somebody and that has a significant measurable mortality. So it needs to be considered carefully, but will need to be utilized as a mode of treatment. So it is unclear if there is a survival advantage for those patients who had late allograft loss if they undergo allograft nephrectomy. So that's not to be a major initial consideration, at least. So the early allograft nephrectomy and high PRA will of course affect the outcome after retransplantation, and leaving the allograft after late allograft loss may have some beneficial effect in reducing allosensitization and for survival of the next renal allograft. So, and this is, this question came up with BK virus nephropathy, and the team from Hopkins published that, you can actually leave the allografts. As long as the BK virus disappears, you can actually leave the allograft, and you can safely retransplant these patients without a nephrectomy. So next question is dialysis, the bread and butter of nephrology. We have somewhat proven now, that early dialysis is probably not a big benefit to patients who are approaching end-stage renal disease, and people tend to stay away from it unless there are other definite indications. So those patients who are tending to need dialysis early on because of their uremic symptoms or electrolyte disturbances or other fluid disturbances, they tend to be males, diabetic with peripheral vascular disease. They tend to have early initiation of dialysis on retrospective studies. So overall picture of the patient, of course, with anyone approaching end-stage renal disease, rather than just the estimated GFR, needs to be considered before this life-changing modality is utilized. So it's an individualized decision. So allosensitization, this is a major consideration for the next transplant, and also for the chronic inflammatory state that happens after transplant fails and the allograft is still in place. So immunosuppression withdrawal is the single most important factor that leads to allosensitization, apart from, of course, the HLA mismatch and pre-existing antibodies, etc. So allosensitization, despite allograft nephrectomy, does happen. So there may be parts of the kidney that's left behind, or the antigenic stimulation has already left a lasting imprint on the immune system, which will not be erased by just removing the kidney. So short exposure to allograft is enough. It is, it's a strong stimulus to have another organ in the body, and 2.5 days of median duration of the allograft being in place is enough to cause allosensitization. So you can have various forms of antibodies, DSAs, donor-specific antibodies, non-donor-specific HLA and anti-HLA antibodies, whether class 1 or class 2 antibodies. So they all have been described in these patients. So of all the causes of Allo sensitization, including pregnancy, blood transfusion, and previous transplant seems to be the strongest stimulus for that. Sorry for this busy slide, but hospitalization after allograft failure, of course, tend to be higher rate of hospitalization. Almost half of these patients get admitted within 6 months with fever, and those who are on immunosuppression tend to have a higher rate of diagnosis of an infection if they develop fever. And such patients who have a diagnosable infection after allograft failure tend to have an increased mortality. And this seems to happen with patients who continue on immunosuppression. So everyone has had these experiences with the patients, and need to be closely monitored if the allograft fails and they are on immunosuppression, and they're back on dialysis. So 30 to 50% following immunosuppression withdrawal develops fever, and some of them will have flu-like symptoms, malaise, and may have allograft pain, typical features of rejection, and maybe a gradual weaning of immunosuppression and maybe an indefinite low dose maintenance immunosuppression may prevent such an episode or such a state of chronic inflammation. However, there's no clear data on what agent, if we extrapolate what causes acute rejection, maybe, withdrawal of calcineurin inhibitor may be one of the most strong reasons to have an episode of acute rejection. Whether you do it slowly, by convention, most people who do it slowly, it may have some benefit by anecdotal experience. Increased risk of bloodstream infection, urinary infection, pneumonia, Clostridium difficile infection, and disseminated histoplasmosis leading to death have been described in patients who are still on immunosuppression after failed allograft. So, there can be mortality associated with infection following allograft failure while they are still on immunosuppression when they go back on dialysis. So, risk of immunosuppression after allograft failure, increased risk of infections per year is much higher on maintenance immunosuppression. And also the mortality risk is higher with cardiovascular causes. Again, steroid-related adverse events. Patients are well aware of this. It's highly publicized. Especially the vascular necrosis, hyperglycemia, myopathy, cataracts, the glaucoma. They all tend to happen if you continue the steroids. Of course, malignancies, Kaposi's and non-Hodgkin's lymphoma, skin cancers. So withdrawal of immunosuppression after allograft failure. To summarize, withdrawal may be necessary in some cases. Practices vary. Gradual reduction, trying to avoid an episode of acute rejection episode, and most people would stop MMF first, a complete cessation, and gradual reduction in CNI, extrapolating from what we did when we had to withdraw cyclosporine after a year of transplant for financial reasons. 25 milligram every 2 to 4 weeks, and tacrolimus 50% every 2 to 4 weeks until they reach 1 milligram per dose, and then maybe 0.5 milligram every 2 to 4 weeks. Seems to be a reasonable way to do it until studies come out to show that there is a way to measure the immune system activation. Steroids, slow reduction or continue maintenance dose. Prednisone decrease 1 to 2.5 milligram, every 2 to 4 weeks, even every month. Maybe a way to go forward, and many practitioners would continue very low dose prednisone in these patients indefinitely, even if they are not a transplant candidate, if the renal allograft is still in place. Okay, so how do you manage an acute rejection episode in a failed allograft? So steroids for the first instance, most would give a pulse or even oral steroids if the patient doesn't want to get admitted, or the rejection symptoms are low with a very close follow-up, and taper to maintenance dose of prednisone over a 4 to 6 weeks period. Allograft nephrectomy, once the allograft cools off, some would do after the first episode, some would do it after the second episode. If it happens, they would just do allograft nephrectomy. So what happens, the immunosuppression is slowly withdrawn and patients enters dialysis and they have developed this chronic inflammatory state. How do you recognize it? Fever with unknown cause where all other causes are excluded. Anemia, erythropoietin resistance. People have measured some protein called resistin in these patients. Elevated erythrocyte sedimentation rate, C-reactive protein levels, malnutrition, hypoalbuminemia, high ferritin level, all points towards a chronic inflammatory state, if other causes are excluded. And the chronic inflammatory state tend to improve over time after allograft nephrectomy, so it's clearly related to an immune system activation against the allograft. So there's some special consideration that happens in a failed allograft recipient. So in a non-adherent recipient, the risk factors in our review of patients were young patients, substance use, prior major psychiatric illnesses requiring hospitalization and major delusions, prior non-adherence related adverse outcome in any healthcare setting, and of course missed appointments, forgetting to take medications other than immunosuppression. They all will eventually lead to non-adherence with the immunosuppressant medications and adverse immunological events and poorer outcome. So these needs to be addressed before retransplanting. Some patients who are blatantly non-adherent, programs won't accept them for a retransplant at all, and they often will go to another program and then they will start the process again and hopefully will do better. So pediatric recipient, recurrent disease, non-adherence, again poorer outcomes with each subsequent allografts, since they need multiple allografts to complete a lifespan. But the interesting thing is, in studies there was no increase in mortality on dialysis in failed allograft recipient pediatric patients versus transplant naive pediatric patients, and that's not so true among adults. Studies do show a higher mortality for a failed allograft recipient dialysis patient, adult dialysis patient, when compared to a transplant naive dialysis patient. So some diseases with high recurrence, FSGS, MPGN, oxalosis, these are special consideration need to be addressed. Most centers would retransplant a first recurrent FSGS patient and would try, not necessarily does it recur in the second case, hopefully. And of course, the risk factors for an early recurrence of FSGS is well known, including a shorter span between diagnosis and ESRD and so on. And so that's again to be addressed. Whether any treatment or immunosuppressive regimen will decrease the risk of such a recurrence is not clearly known at this time. So PTLD, again, patients who have PTLD during their transplant, while the transplant is still functioning and on immunosuppression, they would need of course treatment and complete remission of the PTLD, and may make sure that EBV PCR is negative and need to have a full evaluation for any evidence of PTLD remaining before retransplanting them. We have transplanted patients who have had PTLD, especially cumulative immunosuppression seems to have an effect on it, because some of the patients who develop PTLD post-transplant, they had immunosuppressive management for their glomerular disease prior to the transplant. So before giving immunosuppressive management, including MMF or CNI for glomerular disease, one has to really look at the cumulative effect of such treatment and versus benefit. So that's especially young patients. So those oncoviruses that we can, oncogenic viruses we can measure or do PCR studies for HHV8 in case of Kaposi's, EBV. So those things we can look for. Of course, BK virus, need to be cleared. The other viruses such as CMV, which can have an effect on the overall immune system, as well as specific effect on the renal allograft function. Parvovirus, adenovirus, hepatitis C, B, HIV, all these, measurable viruses need to be addressed prior to a retransplantation. So preparation for a transplant, maybe the immunological risk part is a little higher, and they have to be counseled. Second transplant not necessarily do as well as the first transplant, but hopefully in early transplant failure, hopefully they will do better than the first one. So we divide our workup in our recipient into a cardiac risk evaluation, a cancer screen, serology and infectious disease screen, immunological risk, and imaging to evaluate the anatomy, and also image the chest and abdomen for any unforeseen findings of, for example, a native kidney, neoplasm, etc. And of course, individualized risk, recurrent disease, anatomic features, sensitization, any viremias, may need to do allograft nephrectomy or complete cessation of immunosuppression in some patients before they are ready for the next transplant. A waiting period due to prior malignancies, you can go by the guidelines, and again has to be individualized based on the risk of recurrence and the survival following treatment of such a malignancy. So again, preview of prior allograft studies to identify the etiology of allograft failure, so we don't make the same mistakes that we did, and learn the lessons we need to learn from the previous transplant experience. Prior immunosuppression and careful evaluation of immunological risk, PRA, DSA, cross-match, avoidance of allograft with unacceptable antigens, to reduce the immunological risk as much as we can. Cumulative risk of immunosuppression needs to be considered. So adherence with medications may be to be emphasized, and close follow-up. It's like parenting. There's a free-range care or a helicopter care. Free-range care meaning a little more freedom for the recipient to do what they want, without micromanaging their care. So, but that may not be the best strategy in a second transplant. Because of the higher immunological risk, you may want to look at the levels of the medications and making sure that they are not missing doses and showing up for their follow-up care, and any changes in allograft function is addressed quickly. Immune monitoring, when we can, it's an option when it is really available widely. Which, when patients have many allografts in their body, after years they forget which one is really the working one. And so before we send them to a biopsy, especially it's not done by a nephrologist, you want to tell them which kidney to biopsy, or which kidney ultrasound you are more worried about, as we transplant patients for the third or fourth time. So failed allograft is, to summarize, an increasingly common cause of end-stage renal disease. There were over 5,000 patients in one of the years that they looked at in United States out of over 500,000 patients on dialysis. Prior failed allograft may pose a unique challenge in managing end-stage renal disease due to the chronic inflammatory state, increased risk for infection, and cardiovascular risk. The etiology of allograft failure and recipient characteristics will help individualize care, both for dialysis as well as for a retransplant. Allograft nephrectomy is generally practiced for early allograft failure or recurrent acute rejection episode in a failed allograft. And allograft nephrectomy does not decrease, but may actually increase allosensitization, especially late. There is a measurable mortality and morbidity associated with allograft nephrectomy. Withdrawal of immunosuppression is associated with allosensitization, chronic inflammatory state, and an increased risk of rejection needing allograft nephrectomy. Continuation of immunosuppression reduces the above, but increases the risk of mortality from cardiovascular infectious causes and increased risk of cancers. So what happened to our patient that we were discussing? So Josephine, 4 years after transplant, worsening blood pressure and rising creatinine to 3.8. And Doppler showed external iliac arteriostenosis. Vascular surgery was consulted, and they did actually a crossover graft from the left side to the right side, and the creatinine promptly decreased to 2.5. So 6 years after transplant, even after having a major acute antibody-mediated rejection and an acute cellular rejection and a vascular issue, she has never been dialyzed, and she's recently recovered from a zoster, and creatinine is 2.6, 2.8, and still watching her soccer games. So summary, in conclusion, it's worthwhile to make all efforts to preserve allograft function by actively pursuing all modifiable factors. early preemptive retransplantation with uninterrupted immunosuppression may lead to the best outcome in selected patients in this predicament and should be considered in all cases. So, immunology is like pursuing a unicorn. We don't know where it lives and, where to look for it, and doesn't necessarily have a GPS. And we have very primitive instruments to lead the search and capture. So this is a unicorn tapestries that are in the Cloisters Museum in New York. And you can see that, the capture of the unicorn at the end of the game. And hopefully we can do the same thing with our primitive armamentarium against the immune system and maintain the allograft function. Okay, and that's it. Thank you, and thank you for having me give this presentation and your attention.
Thank you, Madhu, Dr. Bhaskaran, for giving this fantastic presentation and covering so many aspects of manage the issues which we often face while managing a person with a failing kidney transplant. I think there are two perhaps conflicting points which you made, is that while we continue to look for all possible factors which might allow us to continue to get this graft to function as long as possible, it is also important that eventually we have to recognize that a graft might fail, and flogging a dead horse might do sometimes more harm than good. Many of these grafts will fail because of chronic antibody-mediated rejection, and perhaps your opinion about when you do a biopsy in a person whose creatinines have already gone up to 3.5, 4, and the biopsy shows chronic antibody-mediated rejection. How far do you go in trying to do something to preserve their function? Because sometimes in doing that, we may actually do more harm than good.
So that's a very, very good point, Dr. Chai, you made, and we always, worry about doing more harm than good, especially when our, the medication that we use can potentially cause, more morbidity and mortality. Again, my, understanding is that at present we have very primitive tools, not just for measuring immune system but also for measuring kidney function, because we see patients who have creatinine of 3 having uremic symptoms, or sometimes creatinine of 8, 9, maintaining active lifestyle, full-time work for a couple of years. And so I think we are not really measuring the kidney function that leads to quality of life. So when I see patients and I tell my trainees that you got to look at 3 things. One is, what are their acute symptoms? What are the quality of life symptoms, like not able to do the things they want to do? And third is longevity. And when we take care of transplant patients, there are 2 different parallel longevities that we look for. One is the life of the allograft and life of the patient. Of course, the life of the patient trumps everything else. So anything, that's the order of priority will be, the life of the patient, of course. And so again, if a retransplant is a better option than just continuing a heavy dose of immunosuppression or treating an episode of a perceived rejection, again, I would much rather, pursue that second transplant.
Yeah, thanks, Madhu. So I think, as usual, Dr. Bhaskaran's lecture is open to questions. So any of you who have questions, please, as usual, enter the question in the question pane, or do the raise hand. Just click the raise hand symbol so that we can